Okay, thank you.
Okay.
Okay. Okay.
So Mohammed has been doing YouTube videos on this teaching, which has been terrific. So I'm going to bow out, and I'll be in and out just listening. But thanks again, Mohammed. Really appreciate it.
Thank you for the invite. Thank you. Okay, so thank you everyone for coming. I understand this is the beginning of the year, right? So some of you guys are just first-year fellows. Am I correct?
Yes.
Yes. Okay.
I think I'm the only first-year fellow here, but yeah.
Okay. So you know, it might be relatively simple today, but I figured it makes sense because it's the beginning of the year. Okay. So we will start with the ECG. Don't worry about scanning the QR code. This is a case that I would like to present really quick. It's a 2.6 kilo full-term baby who was largely stable, except for high lactates, but otherwise stable. So maybe the first-year fellow could chime in and try to answer to study the ECG.
Okay, big expectations. All right, so okay, so I guess we'll start with rhythm. It does not appear to be normal sinus to me. I'm not seeing upright P's followed by a QRS in 180 yet. So
Okay.
the P waves that I'm seeing don't look like they have an association to a QRS with every beat. Let's see. It looks like there is like different morphologies as we get into our T wave here, at least only two. Looking at our strip, we have kind of this wider complex, and yes, that beat, and then the following beat looks different.
Okay, so you mean different QRS morphologies, or?
Correct. Yeah, different QRS morphology.
Okay. So okay, anyone would like to say something else, guys? Like, what do you think is what is your main diagnosis, or is it? Do you have a main diagnosis, or you can't tell yet? And mind you, the ECG was done with this standard scale, which is 20 millimeter per 1 millivolt, which is like double standard. So everything is a little bit exaggerated. Do you want to call for help?
Yes.
Anyone can speak.
I would definitely be calling for help. So
I think the T wave morphology change is because of the overlying P wave.
Okay.
It seems like the P wave marches through.
Okay.
And I guess my concern would be for a flutter that's not very well conducted.
Okay. Okay. Anyone else? Or should I proceed? I will come back to this ECG later, but anyone else want to say anything else? Okay, let me proceed. Okay, guys. Okay, so obviously, I think you should recognize that the patient is bradycardic for age, right? So, I mean, these are the QRSs, by the way. Okay, so there's one QRS, second QRS, third QRS, fourth QRS, fifth, sixth, seventh, eighth, ninth, and 10 QRSs per 10 seconds. So this is a baby with a heartbeat of 60 beats per minute. Okay. So whenever you recognize bradycardia for age, you have, three main differential. Either sinus bradycardia, or there's ectopy with blocked ectopy with sinus node reset, and I'll explain this further, and a form of heart block. I understand I heard the atrial flutter, but then if you think the patient is having atrial flutter with bradycardia, then there is flutter plus a form of AV block, because it's unusual for a flutter to present with bradycardia. Am I correct? Okay, so if you wanna unify the diagnosis, it's either sinus bradycardia, ectopy with blocked ectopy with sinus node reset, or a form of heart block. Agree, guys? Okay, so these are your three main differential. So, and now we'll get back to this ECG in a second. Okay, so that's another baby who was born at at our institute with, again, bradycardia for age, right? Do you guys recognize? I mean, the heart rate here is what? What's the heart
It's
rate?
like near 60-ish.
Okay, around, less than 80. Okay, so less than 90 beats per minute, which is, definition of bradycardia. So definitely a baby that, there's bradycardia, then you think, is it sinus bradycardia? Is it blocked ectopy with sinus node reset, or is it a heart block? So what do you guys think? What type of bradycardia this is most likely is?
It's like sinus bradycardia.
Yes. So why do you say sinus?
Because the P wave morphology looks like it's coming from the SA node upright in one AVF, and then you have one-to-one conduction.
Yeah. Okay, excellent. So you have, positive P wave in lead 1 and lead AVF, and then, which suggests an atrial activation that's going towards the left side, i.e. positive in the in lead 1, and towards inferior, i.e. positive in AVF. Okay, guys? So the P wave axis is normal for this patient. So most likely the patient is having sinus bradycardia for whatever reason. Okay, so that's a nice example of sinus bradycardia in a baby. And like you said, there's one-to-one conduction. Okay, another example. So again, bradycardia for age in a baby. These are all my patients. Most of them are all my patients. So, I know briefly the history. So what do you guys think is the reason for bradycardia in this patient? Anyone?
So potentially blocked ectopy.
Okay, so why do you say that? So you want to?
Sorry. Yes, I guess
Which-
if you look at that first P wave,
Yeah.
then the T wave
Okay.
looks different than the subsequent T wave.
Excellent. Okay, so there's
So that makes me concerned. There's maybe a P in the T.
Yeah, excellent. So there's PQRST, PQRST, but this T looks different. There is something in that T that is not present in this T, right? And this repeats itself, and that's something. Subsequently, there is a pause after that something, and this, and then the sinus rate for that baby is roughly, this interval, which is, I don't know, maybe 150 beats per minute. This definitely comes in early. Okay. So there's an extra deflection that comes in early without subsequent QRS. So there's blocked atrial ectopy with sinus node reset. Okay, so blocked PACs, and you see those PACs throughout the ECG. Obviously, if those PACs are conducting, then the patient will be tachycardic. But if they are blocking, the patient will have functional bradycardia. It's also very nicely seen in V1, for example. Okay, V2. So T wave there is never a sharp signal within the T wave. It's definitely an abnormal. It's very abnormal for a T wave. So that's definitely almost for sure a P in the T with blocking into the QRS, into the AV node. Okay, guys, clear? So that's called, this is just a nice example of blocked PAC with sinus node reset. The sinus node, if there is atrial depolarization, the sinus node would not depolarize further because, there is already depolarization within the atria, and the sinus node is not aware that the AV node blocked that beat. Okay, so this is normal function of the sinus node, but the patient will, if it blocked, the patient will have functional bradycardia. It's usually benign. Okay, guys, usually very benign. Okay, so it's important to identify that, those blocked PACs, because some people might interpret that ECG as 2-to-1 conduction, for example, which is a different beast much more malignant. Okay. Okay, guys. So again, focus on the T waves, and you see definite, deflection in the T wave that is not present with each and every T wave. And the T wave usually is a very consistent signal, so it should not change beat by beat. Okay. Okay, guys. Okay. So I did show you an example of sinus bradycardia. I did showed you an example of sinus premature atrial beat with the sinus node reset, both presenting with bradycardia, of course. Okay, so like we said, there's a third differential, which is heart block. But first degree heart block, usually the patient is not bradycardic because the sinus rate is often normal, except there is PR prolongation. So typically there's no bradycardia associated with first degree heart block unless there is like increased vehicle tone or something that is affecting the heart as a whole. Okay, but so that's why it's not it's not a main differential diagnosis. So when you are thinking of heart block, you should think of second degree heart block or third degree heart block. Okay, in a patient with bradycardia. Make sense, guys?
Yeah, sounds good.
Excellent. Okay, so that's another patient, congenital heart disease patient with, again, bradycardia for age, and that's the ECG. So what do you guys think is the reason for the bradycardia?
It looks like a second degree heart block. You're seeing prolonging of the PR interval before a drop speed.
Okay, excellent. So there is a gradual PR prolongation and then dropping, right? Gradual PR prolongation and then dropping. Okay, so that's also called Mobitz 1, right? Okay, so so Mobitz 1, which is a type of second degree heart block. Okay, okay, so it's a nice, it's a very nice example of Mobitz 1 in a patient with congenital heart disease patient. Okay, so so again, when you have heart block, you should think of second or third degree, and when the patient is bradycardic, and then obviously second degree heart block is subdivided into Mobitz 1 or Mobitz 2 or 2-to-1 conduction. Okay. So that's an example of Mobitz 1. We just saw the CCG. So there is another patient, again, complex congenital heart disease patient with bradycardia for age. So then why do you think the patient is bradycardic for age?
Yes, this looks like 2-to-1 block. It looks like the conducted PR looks pretty stable.
Okay, except for that PR, right? So otherwise,
yep.
Yeah, this PR is funny, but otherwise the PR is really steady, right? Okay.
Yep.
Okay. Okay. So good observation. So there is a PQRS T. I mean, look at lead 3, for example. PQRS T that is negative, and then there is something at the tip of the T, at the end of the T wave, that looks very similar to the P interval or the P wave, right? PQRS negatively deflected T wave, and then there's again something that looks very similar to the P wave. Okay, and then if you go to lead 2, so that deflection at the end of the T wave is almost identical to the P wave. So presumably that's a P that is blocking. Okay, so PQRS TP, PQRS TP, and so forth. Okay, so there is a definite suspicion of 2-to-1 conduction in this patient, and then you have to look at the entire leads just to confirm. And then wherever whenever you see a P wave, there is very similar deflection towards the end of the T wave. So again, confirming your suspicion of blocked 2-to-1 conduction. 2-to-1 conduction. Okay. So that's an example of 2-to-1 conduction. Usually you cannot tell whether it's Mobitz 1 or Mobitz 2 on a single ECG. But I know this patient, and there are further, ECGs with 4-to-3 or 5-to-4. So we know this patient has Mobitz 1. So this is most likely 2-to-1 Mobitz 1 type ECG. Furthermore, the QRSs are narrow and so forth. Okay, so you cannot tell for sure, but this is most likely Mobitz 1 2-to-1 conduction. Okay, because I know the patient based on different ECGs. Okay, okay. So there is the PP interval should be regular with 2-to-1. So the PP interval is usually regular. Okay, okay, guys, and the PR intervals should be also regular. So the P that eventually conducts should have a similar PR interval throughout. Okay, and the P wave should be sinus in origin, i.e. positive in lead 1 and positive in AVF. And obviously there is a dropped P wave every other P wave. Okay, guys? Easy?
Makes sense.
Okay,
Sounds good.
excellent. Okay, next. So another congenital heart disease patient with bradycardia for age. So I'm wondering, why is he bradycardic? What do you guys
Is
think?
this maybe similar? You see
Yeah,
almost the same PR interval, and then the PP interval looks relatively similar.
excellent. So, I mean, look at V1, look at the P wave, and look at the deflection in the T. I mean, it looks identical to the P wave, right? And the T wave should never look like this, okay? So there is definitely more P's than QRSs, and the P to P interval looks regular, and looks like the P, the P morphology looks, looks identical. So this is another example of 2-to-1 conduction in a patient with congenital heart disease, explaining his bradycardia. Okay, guys? But this patient has also white QRS, for age. And I know this patient further. This is more Mobitz 2-to-1, based on the widening of the QRSs and more ECGs that I do have on his records. Okay. So again, this is another example of 2-to-1 conduction, but this is probably more malignant 2-to-1 conduction. Okay. Okay. Excellent. Okay, another baby. This is not my patient, but this is a patient of my friend in Oman. His name is Dr. Ismail. So he sent me this ECG for a baby who was relatively sick. And my question is he bradycardic? If yes, then why do you think he's bradycardic?
He's probably bradycardic for age if he's a newborn or young.
Yeah.
His rate, his ventricular rate looks to be close to around 100, a little less maybe.
You think it's 100? So where do you think the QRS is? Unfortunately, I know you cannot point to me, but let's study lead 2. So where is the QRS, as you think? So is this a QRS, you think?
I was thinking it was the QRS.
Okay. So,
let me know.
so if this is a QRS,
It looks like a shape with a P wave.
yeah. So if this is the QRS, then what is this? Right. So you have to decide which one is the QRS. Is it this guy or this guy? I mean, you can look
It seems
at
like in lead 3, the second one is the QRS.
Yeah. So this is the QRS, right? Everyone agrees? Okay, guys. So this is the QRS. Okay. So these are the QRS. So do you have more P's than QRSs or more QRSs than P's?
More P's.
Yes. Okay. So there is definitely more P's than QRSs. So, there's definitely abnormal conduction, right? So this is explaining his bradycardia. So now what type of heart block does the patient have? I mean, definite heart block of some sort because there's more P's than QRSs, right? So is it type 2 or type 3?
Probably type 3. It looks like there's not a true association between the P waves and the QRSs. They kind of have their own, like the Q to Q, the R to R interval is stable and the P to P interval is stable.
Okay, but the PR interval, is it stable or different or varying?
It's stable.
Okay, so is this against
Yeah.
complete or with or pro complete?
That would probably argue against
Yeah.
completeness.
Okay. So yeah, so the PR interval is the same throughout, right? Okay. Okay. Agree, everyone, guys? I mean, I'm not measuring clearly, but eyeballing it looks the same, right? Okay, guys. So now it's definitely not complete then, right? So it's a form of a second-degree heart block. Agree, guys?
Yes.
Okay.
Looks
So,
like yeah.
yeah. So what form do you think, like what type of second degree? Is it like Mobitz 1, Mobitz 2, or 2 to 1?
Looks like 2 to 1.
Yeah. Okay. So it's 2 to 1. Okay. So there's P, QRS, P, block, P, QRS, P, block. Okay. So why do you think is he having 2 to 1 conduction? He's a structure normal heart. Unexplained. There's no congenital heart disease. Is there anything
Is that a really long,
newborn? Yes.
like, is this QT really long?
Yes, thank you. QT is so long. Okay, so the QT is like, I mean, I did not measure, I don't remember the QTC, the QTC value, but the QT is, roughly, I don't know, roughly 600 milliseconds, 700 milliseconds. Okay, so the definite very long QT interval. Okay, because the ventricle is repolarization of the ventricle is forever. The P that, the sinus P's are unable to depolarize the ventricle every other beat because of the prolonged repolarization of the ventricles. Make sense, guys? This is, a presentation of long QT syndrome. It's, if the QT interval is super long, some babies would present with 2 to 1 conduction, and usually this is a high risk, patient or mutation. Okay, guys? Understood, guys? Everything, I mean, is it clear? It's a complex ECG.
Yes, that's good.
Yeah. Okay. Okay. So sometimes 2 to 1 conduction is because of long QT syndrome. Okay. Okay. So that's a long QT syndrome patient with 2 to 1 conduction. Okay. So we discussed second degree Mobitz 1, Mobitz 2, 2 to 1 conduction. Well, sorry, Mobitz 1 and 2 to 1 conduction. Obviously, Mobitz 2, you can divide Mobitz 2 into 2 to 1 or, higher grade AV block. And I did show you 2 to 1 Mobitz 2 example previously. So this is a rhythm strip. I don't have so much examples of Mobitz 2. This is a rhythm strip of a patient of ours, again with congenital heart disease. What do you guys think? And the patient had bradycardia episodes intermittently. So what do you guys think is the reason for him to be bradycardic, at least intermittently, based on this ECG or rhythm strip? It might be a tough one without like calipers, but just try your best.
I looks like he's occasionally having drop P's. So after the 1, 2, 3, 4th
Yeah.
QRS complex,
Right.
looks like the P.
Yeah. So P,
I think the P
QRS.
isn't conducted.
Yeah.
I can't tell if it's earlier.
Yeah. So, PQRST, 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 and then there's a P that without subsequent QRS. Okay. So, so there is, there is a P that is blocking here, and then PQRST, and then another P that blocks, and then P conducts and P blocks. Okay. So that's an example of sudden blocking of the P without. So what do you think of the PR intervals, guys? Is it steady or you think it's changing? Just eyeballing it.
It looks pretty steady. It looks steady.
Yeah. So I thought this is an example of Mobitz 2 because there's no preceding PR prolongation, and the return cycle has a similar PR to the to the PR here. So this might be an example of Mobitz 2. Okay. Makes sense, guys? So Mobitz 1, there's gradual PR prolongation before the drop P wave. With the MOBITS 2, there is sudden dropping of the P wave without preceding PR prolongation, right?
So I remember either reading or being told before for MOBITS 2, sometimes you can get grouping of the kind of the beats.
Yeah,
so you have conducted beats, but you don't have to all the time.
for MOBITS 1, you have grouping. So, you see,
Okay.
this is the MOBITS 1. So there's one group, one group. So usually there is grouping of QRSs and a gap, group, gap. So you're right, for MOBITS 1.
Okay.
Okay, excellent. Okay, guys. Okay, so another patient, not mine, this patient, but a complex congenital heart disease patient. Even the patient doesn't have normal sinus P waves, but definitely there is more P's than QRSs. The patient is bradycardic for age. What do you guys think of the reason, or what type of heart block is the patient having? I mean, clear there are more P's than QRS, right, guys? Okay.
Looks a little bit variable. Like in some intervals, there's
so this is
against P waves and some, like more ST2.
Yeah. So is this against complete or with or suggestive of complete heart block? If the R.
I think there's some conduction. Like it seems like the third in the set has the same PR interval.
Yeah.
And the QRS, the R interval changes too.
Okay.
Which would make it seem like the P wave is bringing it in like towards the end as it R shrinks.
Yeah. Excellent. So this is an example of second degree MOBITS 2, with 3-to-1 conduction, at being the most, malignant, most, during the most bradycardic periods. So there's definitely, 2-to-1 here, and then 3-to-1 here, and then 2-to-1 there. Okay. So that's an example of high-grade AV block, which is, a form of second degree heart block. Okay, guys. Definitely not complete because the RR interval is variable, and the PR, the P's that conducts, do have, similar PR intervals. Okay, guys. Okay. So back to the initial ECG. So now you can have another look. So I previously said there might be flutter. The patient might be in flutter with AV node disease. Do you guys have any other thoughts now? So is he bradycardic for age? We said yes, right? We said the heart rate is 60 beats per minute, despite what the machine is suggesting. Okay. So baby with bradycardia again, is it sinus bradycardia? Yes or no, guys?
No.
No, not that.
Because there is what?
We're not conducting. There's more P's than QRS.
Excellent. So it's not sinus bradycardia. Is it blocked ectopy with sinus node reset?
No.
No, because the P wave looks the same, right? There's no different P waves. Okay. So is it MOBITS 1? Is there group beating? No, right?
No.
Okay. So now we're stuck with MOBITS. We're left with MOBITS 2 or complete. So what do you guys think?
It looks complete to me. I don't think there's really any.
The PR, the PR interval is all over the place. The RR interval is regular. The PP interval is regular. Okay. So, the PP interval is regular. RR interval is regular. The PR is all over the place. Each PR is different. That PR is different than this PR, different than this PR, and so forth. There's more P's than QRSs. So this is, there's no evidence of any conduction. Okay. So that's congenital complete heart block. Okay. And this baby underwent pacemaker already, and mom is antibody positive, and so forth. Okay, without congenital heart disease. Okay, guys. Okay, so I thought so. This is the part 1 of the lecture, which is bradyarrhythmia. Any questions? If not, we can proceed. Okay, can we proceed?
Yes, thank you.
Sounds good.
Okay, okay. So, 14 years, this is another ECG for, so we'll change the theme now a little bit, okay? So 14 years old, leukemic patient who's febrile, okay? And then obviously she is, tachycardic, right? And then the question is, why do you think is she tachycardic? What is your main differential? Easy.
Her fever.
Yeah, but like what type of tachycardia does she
Oh,
have?
sinus.
Tachycardia. Okay, easy, right, guys? So, so whenever you recognize the patient to be tachycardic, then you always ask yourself, is it a narrow complex tachycardia or wide complex tachycardia? Okay. And then like in this case, it's obviously narrow complex tachycardia. The QRS are nice and narrow. So then your next question would be, is it sinus tachycardia or is it a form of supraventricular tachycardia? Okay, guys. If it's sinus tachycardia, how do you differentiate between sinus tachycardia or supraventricular tachycardia? You want to study the P waves, okay? The P waves are suggestive of sinus in origin, or the axis of the P wave is suggestive of, sinus in origin, i.e. P is positive in lead 1, P is positive in lead AVF. Then this is most likely sinus tachycardia. If there is difficult to see P waves or the P wave axis is abnormal, then this is most likely supraventricular tachycardia. Furthermore, the sinus rate is often less than 220 minus H. It is usually secondary to something, like in this case, fever, for example. It is usually fluctuating in rate. There is gradual increase and gradual decrease, and there is one-to-one conduction or PQRS sequence, okay? So, so in this patient, obviously she was febrile, so that's expected. The heart rate is not above 210. The P is positive in lead 1, is positive in lead 2, is positive in lead 3, and positive in, where is AVF? In AVF, okay, guys? So everything is pointing towards it being sinus tachycardia, okay, guys? Okay, so another example, 5 years old with palpitations without fever. Just sudden onset palpitations. So what do you guys, so if you go back to the algorithm, is it sinus tachycardia or is it a form of SVT? It's an narrow complex, obviously, tachycardia, right?
Yeah, it looks narrow.
Yeah. So now the next question would be, is it sinus or SVT of some sort?
I guess I'd be concerned for SVT. It's going pretty fast.
Yeah. So it's very fast. It's like, 240 beats per minute, maybe. And then there was no obvious reason for him or her to be, to be this fast. Okay. So, this was an example of an SVT of some sort. Whenever, just study the P waves. And then if you think it's an SVT, then you have to ask yourself, is it regular or regular form of SVT? And then like in this case, it was regular. So then you have, you have a differential, of course, but the main differential would be AV-NRT, AV-RT, or flutter with steady conduction, okay? Obviously, you guys are cardiologists and you guys, you might see junctional tachycardias and so forth, but this is less frequent, okay? So the main differential, especially in an outpatient setting, would be AV-NRT, AV-RT, or flutter, okay, guys? So 2 ECG examples of patient of ours. So this is ECG 1 and this is ECG 2, okay? So both of those ECGs are for patients with tachycardia, okay? For age and narrow complex tachycardia, right, guys? Agree? So narrow, regular, complex tachycardia for both ECGs, right? So like we said, your differential,
Correct.
yeah, your differential would be AV-NRT, AV-RT, flutter, your main 3 differential, okay? Differentials, okay? So in ECG 1, do you guys have any idea which one of these 3 differentials it might be? Or you cannot tell?
I'm not sure I can tell in one.
Fair enough. If you cannot tell, you cannot tell. What about lead
Hard
two?
to-
Not lead two, sorry, ECG two. Two different ECGs.
So just as like another
Okay.
differential, it does look like for lead two, looks like
not-
it's a short P tachycardia.
It's not lead two, it's just another
Or
ECG.
ECG two.
Yeah,
Yes, sir.
ECG two. Yeah. Okay. So both, I mean, both do share the both, both, you can describe both ECGs as regular, narrow, complex tachycardia. Fair enough, guys? Okay. And then if you cannot tell for sure, how can you tell for sure what diagnostic measure you can do to help you with your diagnosis? I mean, both are stable, by the way, just complaining of palpitations. What can you do to differentiate between the differential diagnoses?
Adenosine to try and
Yes.
get to the underlying.
Okay. We said these are two examples of regular narrow non-sinus tachycardia, SVT. So, again, there is no P waves that are positive in lead AVF and lead 3 that you can tell for sure. The patient is really tachycardic for his physiological status, for his age, and so we're presuming it's an SVT of some sort. So you want to give adenosine, like you guys said, obviously should be big flush, good dose, and you want to record the response to adenosine. Okay, so here we gave adenosine at this moment, and we recorded the ECGs, and then bingo, you have your diagnosis. So what do you guys think of the reason for SVT in this patient? Yeah, so this was actually a flutter, patient with 2-to-1 flutter, and then this patient SVT terminated, right? And what do you guys think of the reason for the SVT? Do you think is it more AV-NRT or is it more AV-RT based on the on this rhythm strip? Might be difficult to tell, but you should have a rough idea. Definitely not flutter.
An inverted P wave
Inverted.
after that when it breaks.
Yeah, but I meant, how can you tell whether it's AV-NRT or AV-RT based on, this part of the rhythm strip?
Oh, that I'm not sure.
I mean, don't you guys think there is a hint of delta wave, maybe? I mean, I cannot swear, but, I wonder whether there's a hint of delta wave, okay? Anyways, so, usually it might, just when you give an adenosine to an SVT patient, you might see pre-excitation after termination of the SVT. And if this was the case, then the SVT was most likely AV-RT in origin, right, guys? Okay. Obviously, if there's no pre-excitation, then you don't know whether it was AV-RT or concealed accessory pathway. But if there is pre-excitation, then it might have been because of an accessory pathway. Okay, guys? In any case, adenosine would terminate your SVT, whether it was AV-RT or AV-NRT, and it will unmask your flutter waves if the patient was having flutter type SVT. Okay? Agree, guys?
Yeah, sounds good.
Yeah. I mean, you can study your RP interval, and if it's short, it's more AV-NRT. If it's not short, it's more AV-RT, but I'm not going to go into details here because this is the beginning of the year. Okay? But, there might be a hint of WW here, and the RP interval here is not super short. So these are all suggestive of AV-RT, okay? And then obviously the age of the patient. If the patient is baby, usually it's more AV-RT rather than AV-NRT. Okay, so With AVRT, obviously you have a circuit that is going down your AV node, up an accessory pathway, and down your AV node and up an accessory pathway. Okay. With flutter, you have a circuit that is rotating around your tricuspid valve, and the AV node has nothing to do with the circuit. Okay. And hence, when you give the adenosine, the AV node blocks, but the flutter keeps going. Okay. So adenosine is ineffective in terminating the tachycardia, but it's effective in diagnosing the tachycardia. Okay. Okay. So if you have narrow, complex tachycardia, non-sinus, again, that's an SVT. If it's regular, we said it might be AVRT, it might be AVRT, it might be flutter. But if it's irregular, then it's usually atrial tachycardia or AFib or flutter with variable AV conduction. Okay, guys? So that's an example of a patient who is roughly 7 to 8 years old, who has a narrow complex tachycardia. Is it regular or irregular, guys?
It looks irregular.
Yeah, I mean, yeah, so, you know, the RR intervals here is shorter than the RR intervals here, okay? So there's definitely some irregularity, and it terminates and then resumes, okay? So it's an irregular, narrow, complex tachycardia, okay? Usually when it's irregular, it's unlikely for it to be, you know, sinus. Sinus is usually irregular unless there is, you know, pronounced sinus arrhythmia. But furthermore, you know, when it terminates, you see a P wave, you know, you see a P wave that is different than your tachycardia P wave, okay? So, you know, so this is presumably your sinus P wave, and this is your tachycardia P wave, okay? Which looks different, and the tachycardia is regular. So this is a suggestive of, you know, of an atrial tachycardia. It's an ECG of an atrial tachycardia patient. And again, so the P waves are different. Okay, makes sense. It makes sense, guys. So the atrial tachycardia is often varying in rates and irregular. Okay, and usually it might be intermittent in nature. Okay, it might be incessant or intermittent or paroxysmal in nature. Okay, guys, with a long RP interval. Okay, easy, guys.
Could I just ask real quickly? So the variation is because of the sinus versus the ectopic atrial. That's what's causing the variability, whether the beat's coming from sinus versus the ectopic nature, or is it that the ectopic rate, atrial rate varies itself?
Yeah, so in this case, the ectopic rate is varying in itself. So again, the ectopic rate here is a little bit faster than the ectopic rate here. Okay, and then when it terminates, there's a sinus. The sinus node wakes up, and there's one sinus beat, but then the tachycardia resumes, and again it's a little bit variable. Okay, but in this case, the main reason for the variability is of course the paroxysmal nature of the tachycardia, plus during the tachycardia, the ectopic focus has different or varying rates. Make sense? Okay. Okay, guys. Okay, so so obviously when you have an atrial tachycardia, usually it's a focus, you know, somewhere in the atria, and then the AV node has nothing to do with the tachycardia, and that focus usually overrides the sinus node and just takes control of the rhythm. Okay, guys? So when you give adenosine to atrial tachycardia patient, you will unmask the P waves, but you will not you might, but often you will not terminate the tachycardia. Okay, usually it's ineffective. Okay, so this is an example of a patient with more P's than QRSs, and then when you give adenosine, you do see the P waves that are marching through, and you know the tachycardia cycle length and so forth. Okay, but the tachycardia doesn't stop. Okay, usually. Okay, okay. So these are the main differential for narrow complex tachycardia. I know Dr. Landstrom, Andrew, gave you wide complex tachycardia last week. So I will be quick here. So that's a 2 years old patient, not mine, but I was consulted on. 2 years old patient with palpitations that with this ECG. So really quick, this patient has, how can you describe that ECG? I don't want a diagnosis, I just want description of the ECG. What do you guys think?
Monomorphic wide complex.
Okay, so wide complex tachycardia, that is regular, right?
Regular.
Okay, excellent. Okay, so now you identified the patient being tachycardic, you identified the patient with the wide complex tachycardia, and then you realized the patient was having regular wide complex tachycardia. So when you have regular wide complex tachycardia, you do have three main differential. You know, the patient might be having sinus tachycardia with aberrant conduction, or the patient might be having SVT with aberrant conduction, or the patient might be having antidromic tachycardia, and I'll explain these in a second, or a VT. Okay, guys? Does the main differential, these are your main differential diagnoses. They should make sense in a minute here, okay? Okay, obviously the definition of wide QRS depends on the age, okay? Okay, so this is an example of a wide complex tachycardia, slight tachycardia in a patient who post-tetralogy repair, okay? So that's a patient with sinus tachycardia, okay? With right bundle branch block, okay, guys? Easy. So that's sinus tachycardia with right bundle branch block, okay? Example. Okay, so another patient, post-AVSD repair, okay, or AV canal repair, you cannot clearly see distinct P waves. So you cannot, it's not for certain that the patient is having sinus tachycardia, okay? So what do you guys, you can do atrial wire ECG if you have atrial wires, but I don't want to be complicated. You can do adenosine, right, guys? So when we gave adenosine, again, so this is regular wide complex tachycardia, that is not sinus. Okay, guys, this should be your description of that ECG. Like we said, you have such differential, which is SVT with aberrancy. You have antidromic SVT or VT. Okay, guys, you gave adenosine, and then in this case, it terminated, right? So what would this suggest or rules out?
It rules out like an SVT with aberrancy.
Okay, because why would it? Because why do you say that?
Because you still have a wide complex tachycardia.
Yeah,
After
yeah. So the intrinsic QRS is already wide. Okay, so it was not aberrantly conducted SVT because the intrinsic rhythm is already aberrantly conducted. Okay. Did you rule out antidromic SVT based on this ECG or VT? I mean, yes, right?
Yeah.
I mean,
the QRS complex would be different, right?
Yes, with antidromic SVT, the tachycardia QRS should be different than your sinus QRS. And with VT, the same thing, and the VT usually doesn't terminate with adenosine, right? Okay, so you ruled out VT most likely. I mean, there are some VTs that are responsive to adenosine, but we don't want to complicate things. You ruled out antidromic SVT, and you're left with aberrant SVT, but because the baseline ECG is with right bundle branch block, so this was an SVT with baseline bundle branch block. Okay, guys? Makes sense, guys? Which is expected because post-AVSD, you often have right bundle branch block, okay? Okay, guys? Okay, so that's an example of a patient who had SVT that is going down your left bundle, up a pathway or your AV node and coming down your left bundle, okay? Because the right bundle is blocked post-surgery, okay? Okay, when you have when you have so this is this is just an example of an SVT that is going down normal, down both right and left bundle with a resultant narrow complex tachycardia. And then when the SVT is going down one bundle and the other bundle blocks, you will have widening of your QRS, or you will have SVT with aberrant conduction, whether it's left bundle branch block aberrancy or right bundle branch block aberrancy. Okay, guys, make sense? So this is what we mean by SVT with aberrancy. Okay. Okay. So when you give adenosine to a patient with SVT with aberrancy, the normal sinus rhythm should have a normal narrow complex QRS, not wide complex QRS. Okay. Okay. So like we said, with orthodromic SVT, you have you have tachycardia that's going down the AV node upper pathway. With antidromic SVT, you have a tachycardia that's going down your accessory pathway up your AV node. Okay, so you will have a wide complex tachycardia that terminates with adenosine, because the AV node is part of the circuit. Okay, guys, we have to keep going, right? Okay, so this is back to our initial ECG. Like you said, he's 2 years old, palpitations, wide complex tachycardia, regular. But if you look very carefully, there is clear what, guys? AV dissociation, right? Very nice example of AV dissociation. Everyone recognize that? You see the P waves? Yep. Yeah, the P waves are like definitely dissociated, okay? Which is suggestive of VT. And then, another thing you might recognize that the axis is like right bundle with the superior axis. This might be suggestive of fascicular VT, okay? Which has different implications in terms of prognosis plus therapy, okay? Usually it is very verapamil sensitive, okay? So that for that patient, someone gave adenosine, and there is obviously no termination because we already knew it was VT to begin with, okay? So this is the EC adenosine rhythm strip without termination as expected, okay? Make sense, guys? Okay? Okay.
Sounds good.
Okay, so we talked about sinus with aberrancy, SVT with aberrancy, adenomic tachycardia, and VT. I showed the example of each. And then when the rhythm strip is irregular and wide, like in this patient, 8 years old, pale, with palpitations, very rapid heart rate. She's stable-ish, but very pale and sick looking. So how would you describe that ECG really quick, last minute? Irregular, wide, complex tachycardia, right, guys?
Yeah.
Yes. Okay, agree. Okay, so that's an irregular wide complex tachycardia, and then you should have differential, which is atrial tachycardia with aberrancy, AFib with WW, which usually have a polymorphic QRS nature, or VT, polymorphic VT, VF, and so forth. Okay, so obviously your differential in this case is usually more malignant, and I would caution you not to give adenosine in any irregular and polymorphic wide complex rhythm. Okay. It is contraindicated, okay, because your differential, what do you guys think, by the way, eyeballing this ECG, what do you guys think is most likely in an 8 years old without family history, without congenital heart disease? What do you guys think? Out of these three diagnoses, AT with aberrancy, AFib with FW, or VT, polymorphic VT, or VF?
Is VT?
But there's no SVT. Which SVT?
Oh, sorry. Ventricular tachycardia, like a polymorphic VT.
Yeah, you said VT. Yeah, but I told you there's no family history. There is no congenital heart disease. The patient was super duper healthy.
All right. Well, AFib with WPW.
Yes, thank you.
Excited.
Yeah, so that's his ECG after she spontaneously cardioverted herself, and there is clear WW. Okay, guys? Yeah. Okay, clear WW. Okay. So and then one last example, I think this is a baby with definitely wide complex tachycardia that is regular, ugly looking. The patient was pulseless, was arresting. That's an example of polymorphic VT. or in this case probably more it's definitely polymorphic, but more more monomorphic with slight polymorph, but if you look very carefully, there is definitely some variation, but the QR is very wide for the baby, and the baby was unstable. So it is, in this case, it's VT or polymorphic VT until proven otherwise, and you have to shock the patient. Okay. So this was a general overview of arrhythmias in pediatrics. The main arrhythmias in pediatrics. Obviously, we did not discuss how to distinguish between various wide complex tachycardias that in terms of VT or SVT with aberrancy, because that's not outside the scope of this lecture, and we did not discuss management. Okay, I'm assuming that you guys will get such lectures like down the road. Okay, guys. Questions? Was it easy, useful, guys, or appropriate for your stage, or was it too complex or too easy?
Definitely helpful for me starting out. So
Okay.
I'll speak for everyone else.
Okay.
Yeah, I thought it was very helpful.
Yeah. Okay.
Yep.
Yes, sir. Thank you.
Thanks
Oh.
very much.
Okay.
Thank you so much. I really appreciate it.
Thank you, guys. Thank you, Dr. Salim. I don't know whether you're here, but thank you.
Thanks for taking the time to talk with us today.
Okay. Thank you, guys. I will stop recording.